Well, thank you very much, Steve, and thanks to the organizing committee for the invitation to join you again this year and present a bit about the public health perspective. As Steve said, I spent some time specializing in the management and care of illness of sort of medium-sized and sometimes not very intelligent mammal, the human beings, one species that. But I have learned a tremendous amount from veterinary perspectives and veterinary colleagues over the years. I want to talk about a public health viewpoint on this. In the program, it's also printed, and setting the tone. I guess the tone would probably be about be sharp. I'm not sure I can set the tone. I can share what my perspectives are, I think. This has been going on for quite some time as a fascinating and ever-changing dialogue, and I'm delighted to talk a little bit about the current state. Within that, the care system we have for that medium-sized and not always intelligent mammal, the human, there are two complementary systems, and that those of us in public health are keenly aware of. It's clear that there's the straight healthcare system, and that's the one that tends to be the source of a great deal of antibiotic use. Outpatient clinics, we know well, primary hospitals, where we go as a first order of treatment when we need to be hospitalized, referral hospitals, and the clinical research institutes. And on the public health side, working in parallel, the local health departments, the state health departments, the national health department, which is really CDC, the U.S. Public Health Service, and CDC, in a tiered approach. And these two sectors within human healthcare don't always stay as connected as well as they should be, but I think antibiotic resistance is something that brings them immediately very tightly together. Within the federal government, of course, there are several agencies that are involved, and just to point out quickly, in the arena of food safety, CDC has a non-regulatory role, conducting national disease surveillance. We detect and investigate outbreaks to determine the vehicle and source. We track burden trends and attribution, and try to really improve public health methods and practices for that entire system to use, and provide information to guide action both within the healthcare sector and within other sectors involved in food safety. The FDA and the Food Safety Inspection Service, part of the USDA, of course, are the regulatory agencies, and they are primarily involved in food safety policy, management of problems that are identified, inspecting, monitoring, and enforcing. And they are the ones who would investigate issues on the farm with their state partners and in production facilities. Now, I want to start setting the tone perhaps by saying that antibiotic treatments, of course, have been critical in both human and veterinary medicine since, I guess, the 1940s, and that resistance emerged as a challenge soon after they began to be used, and it's been a problem for almost as long, a challenge almost as long, and it emerges particularly in settings where antimicrobials are used, and when they're introduced, the enthusiasm is high. Boy, this is going to be just terrific. In Japan, after World War II, there were enormous problems with shigellosis, bacillary dysentery, giant nationwide epidemic going on. The early introduction of antibiotic there to treat Shigella in Japan led rapidly to the recognition, oh, look, there's this thing that's happening. They're becoming resistant, and they're able to share the genes for resistance, the property of resistance, with each other. So transmissible resistance was identified in the early 50s there with Shigella. And it appears, of course, in a variety of bacteria or viruses or fungi or parasites, and, as I mentioned, can sometimes spread from one strain to another. Stewardship is our central code word, our central theme, I think, to managing the infections themselves and preserving the effectiveness of the antibiotics we need. Now, probably already mentioned in this symposium, and to come up again, I'm sure, in the future, a report CDC released September 17, 2013, really summarizing the point of the antibiotic resistance threats, the ones that we saw as the greatest hazards. 18 different pathogens were flagged out, including a number of different pathogens that are either hospital-associated or foodborne or different ways of spreading, community-associated. the total burden of a little over 2 million illnesses and 23,000 deaths. Now, the ones that are foodborne, and for us, foodborne is code that says often transmitted through foods. Not always. Nothing is 100%, but often transmitted through foods. 4 of the 18 are often transmitted through foods, 2 of them with primarily animal reservoirs and 2 with human reservoirs. And a slide you may see again in one talk or another is the summary of those, the magnitude of those threats, showing here the percent for those 4 threats: Campylobacter, non-typhoid Salmonella, the specific Salmonella typhi, which causes typhoid fever and has the human reservoir, and Shigella, the percent that are resistant to important drugs that are used to treat them in human illness, and the estimated total number of illnesses per year in that category, and the number of deaths. And the number of deaths is not overwhelming in this summary, but the number of illnesses that we think occur each year is quite large. As I said, there's a variety of reservoirs, and the reservoirs where one can assume that the organism is persisting and managing to get from generation to generation reliably. As I said, for Salmonella typhi, it's humans. For the Shigella species, it is humans, although we also find if we go into even quite virgin primate preserves in Africa, you can find Shigella in large primates as well. For Campylobacter, typically poultry, other birds, and ruminants, especially cattle. For E. coli 0157, it's cattle and other ruminants, although there are 2 troubling outbreaks recently in Canada that are clearly associated with swine. And it makes us wonder, is there something we need to know more about how that organism may be behaving in the Canadian swine herds that would be important to learn more about. For Salmonella, there's a large variety of Salmonella, and they have a large variety of reservoirs. Some are specialists in one, some are generalists and can inhabit many, and transmit and persist in many different animals. The serotype Enteritidis has a poultry association, as does Heidelberg. The multiply drug-resistant Newport has been particularly an issue for cattle, as has multi-drug-resistant Dublin. I'll return to that in a moment. There are Vibrio bacteria that cause a lot of human illness, and they typically are related to shellfish and the microorganisms, copepods and others that shellfish feed on. Yersinia colitica in swine. One of the things that's important to us, and it is a real factor in the way we think about this, is that those with animal illnesses are often not associated with, those with animal reservoirs are often not associated with animal illness, and that gives us this collective challenge of dealing with something that's largely a commensal in the host species, is rather well adapted to it, but when we eat that host species, we may be exposed to it, and it makes the human ill. Why are we concerned about the resistant strains particularly? Obviously, one of the central issues is that when treatment is needed, early empiric treatment based on, it's a Salmonella, we'll treat with this, or a Shigella, we'll treat with that, could fail, and treatment choices are going to be more limited. We have observed in a number of occasions and epidemiological settings increased morbidity and mortality associated with resistant infections, longer illnesses, more invasive, more likely to be hospitalized, more deaths. Treatment for another condition, if I have a low dose of Salmonella, I'm carrying it at a low level, and then I take an antibiotic for some other reason to which that Salmonella is resistant, it has a sudden selective advantage. It can convert my silent carriage into overt disease, complicating whatever I was originally getting the antibiotic for. And when multiple resistance genes are grouped, use of any one can co-select for all the resistance genes. And as I noted, resistance on a mobile genetic element can transmit to other bacteria horizontally. We address this challenge at CDC in collaboration with other agencies by tracking resistance through the National Antimicrobial Resistance Monitoring System, or NARMS, testing isolates from ill people, FDA testing isolates from meat and poultry purchased at retail, and FSIS testing isolates from animals at slaughter. We're making real-time resistance data more and more part of the outbreak investigations we do, and trying to make that information more quickly available at the NARMS Now website. We're refining the understanding of the sources and spread of the resistant strains and the genes and plasmids involved, and estimating more about the health impact of the resistance itself. And as the previous speaker noted, no trivial part of this is actually working with partners to prevent foodborne infections in general, preventing infections of all foodborne infections, whether they're resistant or susceptible. Now, a little bit about some of the trends in antimicrobial resistance in Salmonella that we've been observing in the United States. Here are the data from NARMS, the recently updated through 2013. We hope to have 2014 out shortly. First, there is good news, which is that the multi-drug resistance, that is at least 3 different agent classes, an organism resistant to at least 3 of the agent classes tested, that is in a long-term and slow decline. Back in the late 90s, it was 16% of Salmonella had multi-drug resistant, defined that way. By 03 to 07 period, it was 12%. In 2013, it's 10%. This represents a slow and steady decline in multi-drug resistant that I think it's important to recognize. It represents the sum total of a lot of different things, probably, but overall it's good. Now the thing is, we want it to go even lower. And when we look at that 10% that are resistant in 2013, 70% of that can be accounted for within 4 serotypes of Salmonella. If we just look at which serotypes are the most resistant, now we can reduce the discussion to 4 serotypes. The most resistant one is Dublin, Salmonella Dublin, which is a problem in cattle and humans, more in cattle than humans, I think. Another one is I4512I-, a serotype that has recently been derived from Typhimurium. It has evolved from Typhimurium. And over half of them are resistant. Heidelberg, the poultry-associated serotype, is a third of them are multiply resistant. So, and then Typhimurium itself, 17%. So the average for all of them is 10%. But these resistant serotypes, particularly resistant serotypes, account for a lot of the problem. Then I want to focus out just one comment on ceftriaxone resistance itself. Ceftriaxone is a really important drug for invasive infections in human medicine. And only 3% of all of our non-typhoidal Salmonella are ceftriaxone resistant, thank goodness. But if we look down at our friend Dublin, 92% are. It's extremely high levels of resistance. Heidelberg, 15%. So again, certain serotypes are contributing to the problem. And then quinolone resistance, including under the broad heading of resistance, reduced susceptibility. Again, it's 3% of non-typhoidal Salmonella, but the serotype Enteritidis accounts for more than its share. And we are seeing the occasional plasmid-mediated quinolone resistance, which is a new phenomenon for us. So what this looks like, here is a graph of the resistance in Salmonella Dublin isolates. Resistance to ceftriaxone, or it's basically the same as ceftiofur resistance. And from 1996, when NARMS started, till 13, and here are 2 lines, for isolates from humans and for isolates from cattle, and you can see that they pretty much parallel each other. This is the ceftriaxone resistance, which for Dublin means multi-drug resistance. And almost all of them have this unpronounceable long formula of ampicillin, chloramphenicol, streptomycin, sulfa-tetracycline, augmentin, and ceftriaxone all together. And we're concerned about this. It's been an issue. I know Salmonella Dublin is a real problem in those raising calves. And it's an unusual organism. It's an invasive organism. When it comes up in a human, it's usually in their bloodstream. So it's a problem for humans as well, although not a particularly common one. We've seen 9 strains from humans since 2007 that also had a lower susceptibility to fluoroquinolones, and 6 of those 9 were both ceftriaxone and fluoroquinolone resistant, and that means we're really starting to have very, very few drugs left. I was delighted to learn that in fact there is a commercial bovine vaccine for Dublin, and perhaps there is some other way out of this for us, for the veterinary community and for the medical community, other than chasing down the last few drugs that still work. Now, another one is this multi-drug resistant salmonella that used to be called monophasic typhimurium. We now give it its formula, 4,5,12I-. This is increasing now, and it is number 5 among human strains, and continuing to sort of increase, while some other serotypes decrease. So it's really noteworthy for that. And as it increases, it's becoming more and more resistant. In 13, for the first time, over half, 51%, were multi-drug resistant. And I have a graph here that shows what is this is from our NARMS Now site, showing the percent resistance to ampicillin. And that's from 1996, I think, the first dot, up through 2013, and you can see that the ampicillin resistance, which is a marker for the multi-drug resistance, is really rising quickly. It's the same resistance, the same pattern, and the same strains are present in swine and beef cecal samples that the USDA started doing, and it's been found on pork chops. And there does seem to be a hint that there's an association frequently with swine, or at least with pork. Recent outbreak in Washington State with 152 cases of this characteristic pattern, ampicillin, streptomycin, sulfone tetracycline, was linked to roast pork and other pork from one plant that was led to a recall, and the plant was closed to revise their processing. That's the outbreak curve from that. Now, this strain, it actually emerged with this level of resistance in Europe in the 90s, and then it came to Canada, and then more recently to the United States. And it's, I think, a multinational concern, and it's one that I think we can have a collective concern about. Here's another story about something that happened in another country and then came here. The Pasteur Institute has been following Salmonella Kentucky that comes they're in Paris, and they get visitors who come back, or travelers who come back from other parts of the world. And beginning in the 60s, they saw Salmonella Kentucky coming back from people visiting Tunisia, North Africa. And by the 90s, they were seeing it coming in from visitors still to Tunisia, but also Egypt, and it had become more resistant, and they've been tracking this. And by the 2000s, it was also from people coming back from India, and it's becoming progressively more and more resistant. And then in 2008, the same strain really appeared in Polish turkey flocks, turkey meat, and in consumers in Poland, and then since then in turkey flocks and meat and consumers in Germany and France. And it's all one genetic lineage that's become more and more resistant, most recently to that string of antibiotic agents, and including ciprofloxacin and sometimes ceftriaxone. So that's also of concern. We looked in our data, we've seen it 6 times in NARMS in the last few years, all in travelers who come back from North Africa or Asia. And although Salmonella Kentucky has a reputation in this country of not causing severe infection all that much, 2 of these people were hospitalized and 1 died. So they're not all alike. I want to finish with one comment here about Ciprofloxacin-resistant Shigella. This is one of the human reservoir organism. It spreads from human to human via food, water, direct contact, typically in settings with poor hygiene, one of which might be, say, a child care center with diapered kids running around, not washing their hands very often. And this, it can become resistant rather rapidly. And as of 2013, 54% of the Shigella in NARMS were multi-drug resistant, typically ampicillin trimethoprim sulfa, which is what we used to treat Shigella with. Now ciprofloxacin is the first choice for adults, and recently resistance has been increasing, and this was mostly seen in travelers coming back from other parts of the world. So here's an outbreak, Shigella sanii, and the epidemic curve there down in the bottom left-hand corner shows a number of cases. Those are color-coded or shaded to show they're coming in from different countries, India or other countries. So these are travel-associated cases coming in to the San Francisco area, or to the United States. Sorry, I think this is all U.S. And then, boom, there's this big spike of the gray cases that are not travelers. These are the San Francisco homeless population, which had a really impressive difficult to manage outbreak that was resistant to ciprofloxacin, as were all those cases that were coming in on travelers. So it was coming in on travelers. It got into the homeless population. And the challenge then was large for public health. How do you promote hygiene, you promote access to toilets, and you set up better guidelines for use. What are you going to treat it with? And the principle of reserving the antibiotics that still worked for the patients who had severe illness or immunocompromise was articulated. This is a difficult situation, and we can anticipate more of these. So in humans, of course, antibiotics are among the most commonly prescribed drugs. As much as 50% of antibiotics prescribed for people are really not needed or are not the best choice, and antibiotic stewardship is critical to prolong the usefulness of the antibiotics. Absolutely, and you'll be hearing a great deal more about this tomorrow from our specialists from the who deal with the human use of antibiotics in hospitals and in community settings. And they have defined the core elements of antibiotic stewardship in a hospital setting where you have the most control over what's going on. And very quickly, it starts with defining it as a problem and a program with leaders and accountability, implementing interventions to improve the use, such as restricting the use of certain agents requiring prior approval, revisiting empiric treatment decisions routinely after 48 hours to see if they should be adjusted now that the lab results are back. And then tracking the patterns of antibiotic use and resistance, reporting regularly to the community in the hospital, the staff, on the use and resistance, and educating practitioners and staff, and modifying policy going forward, depending on how it works. I think, I want to say from my point of view, from the public health perspective, that expertise in animal health and health management in this room is vital to address the resistant foodborne zoonotic infections, reducing the introduction of resistant strains or genes into the production environment, reducing the spread and selection of resistant genes or strains in the animal production environment by looking at the policies that would reduce selective pressure, the practices that prevent the spread of infection among the animals, and implementing antibiotic stewardship and prevention measures, as been discussed before. One of which, at the bottom, is, of course, measures that reduce the contamination of the food itself. So I think we continue to have a substantial and changing challenge to human and animal health. I don't view it as necessarily irreversible, related to both agricultural and human uses. The multidisciplinary networks and partnerships that we have in this room, a good example of, are vital to the progress to limit the emergence of resistance and prolong the utility of current antibiotics with stewardship and better tracking of human and agricultural use. Our collective goals, I think, are on the food side are pretty clear. We want the food to be safer, those who eat it to be healthier, people to have more confidence in the food supply, and for effective agents to be available for humans and animals who need them.